All right. Well, good afternoon, everyone, and welcome to this, our 36th session of MRF HIV STI ECHO. I am Dr. Boyce. I am the facilitator this afternoon. Welcome to our in-house family and our out-of-house family. Just to my left is Dr. Jeffrey Edwards, our director, and to my right is Dr. David Musa. He is one of our physicians and I don't say our psychologist, but training in psychology, who wears both hats with great skill. So we're going to start off today's session with a presentation on some research that Dr. Edwards did in our own clinic about syphilis among men of sex with men. So I'm going to switch over to that presentation. Just give me a second. All right, can everyone see the screen? Is everyone seeing the presentation okay? Yes? Good. Okay, Dr. Edwards.
You seen it?
Yes.
Good afternoon, everyone. So I'm going to present a study that we conducted last year, 2019, of syphilis among men who have sex with men attending the MRF clinic. Okay, next one. So I'm going to talk about a bit of the background, the objectives of the study design, the methods, the results, conclusions, and some recommendations. I did this for the dermatology conference about 2 weeks ago, so I'll show some pictures and I'll talk about dermatology, but it's a general thing. Go ahead. So syphilis is an inflammatory genital ulcer disease caused by the spirochete Treponema pallidum. If syphilis is left untreated, it could result in severe complications and sequelae, all right? And syphilis could enhance the acquisition and transmission of HIV infection. The genital ulcer actually acts as a portal for entry, and the inflammatory response, it recruits the inflammatory cells like the CD4 cells, and those are the targets for HIV binding. So data from the CDC show that in the USA, the incidence of syphilis, it increased from 9.4 cases per 100,000 in 1977 to 14.6 cases per 100,000 in 1982. And this increase was mainly due to an increase in syphilis among men who have sex with men. Then the HIV epidemic started in 1981. So during the 1980s, there was an overall increase in the incidence of syphilis in the USA. However, there was a decline in syphilis among men who have sex with men because I said the HIV epidemic, HIV was first diagnosed in 1981. So, I mean, during the late 80s, I mean, things like safe sex and stuff was coming the norm. There was no antiretroviral therapy. So, men who have sex with men were not taking as many chances as they did before. And then some of the bathhouses and some of the areas where they had high-risk behavior, they closed some of those things down. So even though there was an overall increase in incidence of syphilis in the USA, there was a decline in the incidence of syphilis among men who have sex with men. Next one. So in the 1990s, the incidence of syphilis was at its lowest ever because, as I said, during the height of the HIV epidemic, treatment only became available in 1996. So, I mean, people were taking less and less chances out there, and people were using condoms, they had reducing the number of sexual partners, etc. So, in the USA in the 1990s, syphilis was mostly occurring among the heterosexuals and ethnic minority groups. So, the African Americans and the Hispanics. And actually, CDC advocated for a syphilis elimination campaign. However, antiretroviral therapy came into being in 1996, all right? So people began to realize that HIV is no longer this disease that kills everybody. People could live long and healthy lives with HIV, and you can suppress the viral load. So in the 2000s, there was a resurgence of syphilis among men who have sex with men. Again, the high-risk behavior increased. Things like PrEP came into being. All right, so globally, MSM are disproportionately affected by syphilis. And looking at the studies, a lot of the MSM media partners on internet dating sites, Grindr, and all these different sites, people have WhatsApp groups, lots of sex parties going on in Trinidad and other parts of the world. So hence there was a resurgence of syphilis among men who have sex with men. So in the USA, between 2017 and 2018, the reported number of cases of primary and secondary syphilis increased by 14.4%, and 64% of these cases occurred in MSM. Next one. In 2013 in Trinidad, Mungru et al. Studied 64 confirmed cases of syphilis at the STI clinic, QPC-CNC, and found that 36.6% of those cases were diagnosed in MSM. I conducted a study at QPCC when I was director at QPCC, looking at the prevalence and risk factors for STIs among 210 HIV-infected patients who attended the QPCC clinic. And I found that among the HIV-infected patients, the STI prevalence was 37.1%, which is quite higher. So people who knew they had HIV still have an unprotected sex, and 37.1% of them had a STI. The STIs were more common in MSM, and the most commonly diagnosed STI among the MSM was syphilis. Next one. So there's no data on syphilis co-infection in HIV-infected MSM in the Caribbean. So the purpose of the study was to determine the prevalence of syphilis and to explore risk factors contributing to syphilis infection among men who have sex with men attending the MRF clinic. And I also looked at the cutaneous manifestations of syphilis in MSM. Next one. As you all know, the MRF is the largest HIV treatment clinic in the English-speaking Caribbean. And as of December 31st, 2019, we had 6,434 patients currently enrolled in active care. And of these, 688 were self-identified as MSM. Now, we think this is quite underestimated because usually the data is captured at first visit when patients come to clinic, and if the patients are not comfortable, they probably wouldn't self-identify as MSM. Later on, once they get more comfortable with the staff, they then identify as MSM. So I think that 688 is an underestimate. So as part of the routine care at the MRF, data is collected on all patients using a pro forma surveillance form, and this will include the demographic data, so age, sex, address, etc., ethnicity, their sexual orientation, past history of STIs, education and employment status. And all patients coming into MRF are offered a screening test for syphilis. Next one. So a chart review study of the prevalence and risk factors for syphilis among men who have sex with men was conducted among patients attending the MRF clinic between January and December 2019. This study was ethically approved by the Institutional Review Board, Faculty of Medical Sciences, University of the West Indies. So again, to carry out a study after ethical approval. The inclusion criteria for the study were HIV-infected men who have sex with men, either homosexual or bisexual, attending the clinic. And the exclusion criteria were, of course, HIV seronegative individuals, females, and patients who self-identified as heterosexual. Next one. So testing for syphilis is usually carried out once a year at the MRF clinic in MSM or at the discretion of the treating physician. And this is done at the MRF laboratory. We usually screen the sera with a non-treponemal test, the VDRL, and then all reactive samples are confirmed with a treponemal test, the treponema pallidum particle agglutination. Then we extracted data from the client records and the laboratory logbooks to obtain the clinical and laboratory diagnosis of STIs. And then we analyze the data using SPSS version 25. Next one. So during the period, January to December 2019, I was able to determine that 218 MSM were screened for syphilis. The age range was 19 to 67 years old, the mean age was 34. And 31.7% of the men were actively bisexual. Next one. So if you look at the slide here, you can see that the majority of men, the age group was between 25 and 39 years old. Most were Africans, 53.7% were Africans, and 33.9% were mixed. And as I mentioned before, 63 or 31.7% were actively bisexual. Next one. And in terms of the prevalence now, the prevalence of syphilis among men who have sex with men was 41.3%. That means 4 in 10 MSM were positive for syphilis. That's really high. That's alarmingly high. All right, 41.3% is alarmingly high. Next one. And then we looked at the stages of syphilis. And remember, I had to do this backwards, so patients are already diagnosed. So in terms of primary syphilis, we saw no cases. A lot of patients present with secondary syphilis. That's the rashes, on the palms and soles, and the rash on the rest of the body. And a lot of the patients present with latent syphilis. Latent syphilis means that you have a diagnosis of syphilis by a blood test, but no signs and symptoms of syphilis. So of the 90 patients diagnosed with syphilis, asymptomatic infections, which is the latent syphilis, accounted for 71.1%. So most of the men had syphilis and didn't know they had syphilis. And the only reason we diagnosed it is because we did a blood test on them. Next one. So we're looking at the risk factors now. And if you look at the risk factors, again, none of the risk factors are really significant. You can look at the last column in red, you can see sexual orientation. So bisexual men were twice as likely to be diagnosed with syphilis, all right? And patients with a previous history of syphilis were 9 times more likely to be diagnosed with syphilis. That's the only one that was statistically significant. So bisexual men and persons with a previous history of syphilis. The others, in terms of age group, alcohol or other drug use, CD4 count, antiretroviral use, viral loads, were not statistically significant. Next one. And then what we did something called a multivariate analysis, where we tried to put all the risk factors together to reduce any, say, confounding or any bias, okay? And then looking at the data, we found that men in age group 25 to 29 years old were 4 times more likely to be diagnosed with syphilis compared to the younger men. The bisexual men were no longer significant. And patients with a previous history of syphilis were 10 times more likely to be diagnosed with syphilis. So what was happening is that people who were being diagnosed with syphilis, they were being treated, all right, and then cured, and then being reinfected. So people were being, and then a lot of them were asymptomatic and they didn't know they were having it, so they were spreading it also. So we had people going around in a circle, all right? So if you have a sexual circle, people will get infected 2 and 3 and 4 times. And again, a lot of them were asymptomatic, so they didn't know they have syphilis. So we were treating them, curing them, and they were being reinfected. Next one. And then this is just some of the skin signs of syphilis. As you can see, you can get a rash on the body. Next one. It may affect the palms and soles. This gives you the diagnosis, but you don't have to. So if it affects the palms and soles, it's good, we can make the diagnosis, but we don't have to. Next one. Again, you can see it affecting the palms of the hands and soles of the feet. Next one. You can see it on a rash on the trunk, on the body, on the chest, and on the abdomen, but we got a diagnosis because you can see the rash on the palms. Next one. This patient actually just presented with hair loss. He said, "Doctor, losing my hair," and when we screened them, so on the syphilis is a multi-system, it could affect all areas of the body. So hair loss alone, and this was his only symptom, was his diagnosis of secondary syphilis. Next one. And then I noticed quite a few men presented with these. If you look at the penis there, you see these rounded, oval, scaly, slightly hypopigmented, slightly lighter color, rounded lesions on the penis there. And this was a diagnosis of syphilis. So some of them didn't have any lesions on the palms or soles, but they had these lesions on the penis there. And because of that, we were able to make the diagnosis of secondary syphilis. Next one. And again, you can see on the scrotum there, see the these lesions here are kind of slightly raised and, you know, slightly lighter in color, all right? Lesions of secondary syphilis. Next one. And then this man presented with those things on his face there around the chin, and I asked him, let me take a look at his genitals, and they could see the same lesions around the mouth ears on the genitals. So again, these are lesions of secondary syphilis. So any strange rash you see in a patient, you need to screen them for syphilis, especially if the rash is not itchy. So the secondary syphilis rash tends not to be itchy, and any strange rash you see, you need to screen them. Next one. So in conclusion, this is the first study from the Caribbean region to demonstrate the patterns of syphilis co-infection in HIV-infected patients. The prevalence of syphilis among HIV-infected MSM attending the clinic was quite high, 41.3%. Asymptomatic syphilis, meaning no symptoms, accounted for 71.1%. So the men who walking around with syphilis didn't know they have it. And then repeat episodes of syphilis, many that are asymptomatic. So the men again, syphilis, being treated, picking it back up again, and spreading it among their circles. And we thought this may play an important role in the dynamics of syphilis in MSM attending the HIV clinic in Trinidad. Next one. Now, there's some limitations of the study, just to mention. It was a retrospective design, meaning we went back in time. We had to extract data from our existing database, so hence we couldn't ask questions such as the frequency of sexual intercourse, the type of sexual activity they're having, who was a top, who was a bottom, you know, condom use in among sexual partners. I mean, that was not available. So actually what we're doing right now, we're doing a prospective study where a questionnaire is designed. Men who have sex with men usually come into the clinic. We'd ask them if they want to take part in the study. We'd let them fill out a question and we do a test for syphilis in them. And Dr. Boyce is actually seeing, once you get back the results, either positive or negative, Dr. Boyce is seeing these men in the men's health clinic on a Wednesday. So if the syphilis positive, he'll treat them for syphilis. If they're syphilis negative, again, he'll counsel them about, you know, risk factors and stuff for syphilis. So we think that the prevalence of syphilis is likely an underestimate because a lot of men attending our clinic may not have self-identified as MSM. All right, they may not feel comfortable doing it. All right, next one. So we want doctors, as a dermatologist, to screen all MSM for syphilis and HIV. Physicians should conduct full skin examinations, including the scalp, I showed you the hair loss, the mucous membranes and the anogenital region, because I showed you those lesions on the penis and the scrotum. And then we need to put some HIV, STI prevention programs, which is what Dr. Boyce is doing now, and the Men's Health Clinic for MSM should be strengthened. Okay? So thank you. That's my presentation. These are the references.
Thank you, Dr. Edwards, for that. Very interesting. I mean, this was just, I think, retrospective, just to see what the state of play was.
Yeah.
Right. So, are there any questions at all? Hi, Conrad, go ahead.
I don't have a question, but I do have a comment. It was interesting that you saw that increase happening around 2000, because within the MSM community, you know that the late 90s into the 2000s is really when social media really started to play a huge part in the way that persons actually connected and met each other. And in many ways, that also sparked off a lot of the sex parties that you would have had online, because not online, but would have been initiated online. Because what then happened is you had specific sites, not just for gay men meeting other gay men, but just as you were getting into 2000, you started having online sites for HIV positive men to meet, to have sex with HIV positive men. So it was interesting that it talked about that increase around in the 2000s. And I just wanted to share a quick short story. In Palm, we had someone who came to us in February.
Everybody doing this background thing in
Zoom. In February, someone came to us in Palm and we redirected them to go for testing because they were talking about the spots in their hands and stuff like that. That was in February. Lockdown came in March. They hadn't gone. It was only around, we're in November now, it was only around early October that they came back again to ask to be redirected for testing. And at that time, it was only because they had gotten a discharge. They were starting to get a discharge in their penis. So when you look at that, this is someone who was told maybe you should go and be tested in February and only did so when it became urgent in October. And so often that is what you find happening in the MSM community, because if signs are noticed, they are ignored or persons are afraid to go. And so a lot of times a syphilis infection might actually stay for quite a long time before it's identified or tested for anything of that nature.
Right. The issue is we used to refer patients to QPCC for testing and treatment and stuff, but we realized that they don't go. So what we have decided to do now, we are treating our own patients here at MRF. So if we diagnose with syphilis, we treat them and ask them to bring in their partners. It's interesting you mentioned that thing about the HIV positive men have the sites that's called zero sorting, you know, so they have things where patients claim that they're HIV negative and they go with HIV negative people, or people who are HIV positive go with HIV positive people. But again, it don't work all the time, because I had a patient recently diagnosed because he had a status as HIV negative on the site, and somehow, you know, he got HIV infected. So again, what they try to do is zero sort. The HIV positives could have sex with HIV positives, and supposedly HIV negatives could have sex with HIV negatives, but not sure. Conrad, you could tell us about that? A little bit how that.
Within the community, there is, and when I say within the community, within the HIV positive community, PLHIV community of MSM, there is an undercurrent thought that the one thing that a positive person could do that normies can't do is that we can have sex unprotected. And so it becomes like the last bastion of freedom, because there's so much stigma and discrimination. It's seen as difficult to find a partner, openly speak about your diagnosis, enter into a relationship with someone if you have to share with them the fact that you're positive, get someone who will stick with you after they find out you're positive. And so some persons, some MSMs that are positive actively only look to meet other MSMs that are positive because there is less work to be done. Towards this end, in a lot of the social media sites, now persons meet not just for socialization, but primarily for sex. And there are tags that are associated with this, such as you would see PNP, which means party and play, which means that they would use drugs and have sex. There's also H and H, which means high and horny, which means that there are already drugs here, so you can just come. And so there are all of those kinds of labeling that are happening on social media, so that the sex has become easier, more rampant, more targeted. And as I said before, there are sites that are just primarily for persons who are HIV positive, going so far as to have sites that only promote bareback sex or sex without condoms. So there's an internationally recognized site called barebackrealtime.com or BBRT. There are many other sites like that as well. On top of this, you also have the fact that more and more MSMs are turning to sex work through social media as an added form of income. Recently, there's been a huge upsurgence in the website called Fans Only, which means that a person can ideally stay at home, invite friends over, have sex, film it, put that up to a protected site and get money from someone else, you know, paying to download to see that. So it means now that anyone can be a porn star, get money from it, but because the request more than often is for unprotected sex, it also means that there is no industry guidelines that talks about making sure that persons are tested before they come for these interactions. There's no kind of industry guidelines to protect persons from speaking the truth. So a person might say that they're negative when they're actually positive. And just one more note to say that even on these social media sites, a lot of persons were saying that they were positive, but sorry, I'm saying that wrong. They would say that they're on PrEP, when actually what they are is positive and undetectable, which means they're on HIV medication. But they would twist the truth, and instead of saying that they were positive but undetectable, they would insinuate that they were on PrEP and that therefore they were negative.
Okay. No.
It's just becoming a little bit more interesting, because even from Dr. Edwards' presentation, syphilis has been increasing dramatically amongst the MSMs. And then we've reached this unfortunate, but at the same time unfortunate point where we're telling the patient that undetectable equals untransmissible. But we're only talking about HIV, we're not talking about syphilis, which is also becoming rampant. So like Dr. Edwards said, I think we need really to up our efforts in reminding our patients that syphilis is real, and as much as they might not get HIV from their HIV positive friends or partners, they have higher chances of getting syphilis. Now, my question to Dr. Edwards is, the number of people who get syphilis, you test them again and they're still positive. How do you differentiate those who are serofast and those who are really reinfected?
Right. So when you test somebody with syphilis and you treat them, the VDRL usually goes down. Sometimes it goes down to negative, sometimes it goes to 1 and 2, 1 and 4. Yeah. And then when they get reinfected, it goes back up. If there's a 4-fold increase in titer, yeah. So it goes back up. So that's how we can tell they're reinfected. Because usually if they serofast, they might say like 1 and 4, 1 and 2. But then if they are reinfected, it might go to 1 in 32 or 1 in 64. And that's how we can tell. And they will tell you that they are the exposure.
So we have one patient that I think he's been in the clinic for a long time. He's been treated here, he's been treated in England.
No, right. So there are a few patients, as he mentioned. Like when I was in QPCC, we used to see a few patients who you treat them 5, 6, 7 times and their VDRL will always be positive, say 1 in 256. And they recommend those people should probably get admitted to hospital, get a lumbar puncture, and be treated for neurosyphilis. So that's what they recommend for those patients. Yeah. So that's IV penicillin for 10 to 14 days. But there are patients like that, the syphilis tests don't go down.
So they actually still have the active infection.
I don't think it's active infection, but I mean, just to make sure, because it's not going down, they recommend that you should probably refer them to hospital and screen them for neurosyphilis. So do a lumbar puncture. Yeah.
And just to interrupt that and say as well, I think a lot of MSMs are unaware of what the signs for syphilis are. So there needs to be a huge amount of education about that in the community, because persons don't know what to look for. And so that's why when they see stuff on their skin, they're concerned, but a lot of times fear might keep them quiet. So because they don't know what it is and it's not hurting and it's not paining, it's not itching, it's not leaking, then they just don't bother about it. And they think it's stuff like Lota, and things like that, rather than recognizing that it could be something that's very significant.
And the thing about it in our studies, that 71% of them had no signs and symptoms. They had latent syphilis, so they were walking around with it and didn't know they have it. Only reason they found that we did the test. So syphilis in some of the MSM, at least 70% of them was latent, no signs and symptoms. So nobody really know they have it. Yeah.
Just one quick question about, in terms of PrEP. So you mentioned in your presentation about the impact that PrEP may have had into changing sexual behavior and risk compensation, all sorts of things. Some of the earlier studies had suggested that there was actually no increased risk of STI with PrEP, but some of the later studies are saying, well, actually, yes, there is. Can you give some insight as to what the impact of PrEP has been, at least so far.
Yeah, well, PrEP, the impact of PrEP, meaning that the prevalence, I mean, if patients take PrEP, it really works well. So the risk that you get in HIV will be really low. So it really works great for HIV prevention. But a lot of people are getting syphilis, gonorrhea, chlamydia, genital warts. So a lot of the studies now are finding that patients on PrEP, there's a high risk of STIs among them because they have unprotected sex. But once they take PrEP consistently, they don't get HIV, but they get the other STIs. Yeah. So PrEP works to prevent HIV.
I'm
So
seeing a
there's a
question.
question. Okay.
Oh, sorry. Okay, from Joseph. Good afternoon. In regards to steroidfast action, what relation does it have with syphilis being cured and the TPP reactivity for lifetime?
Yeah, so what we're saying is some people, even though you treat them for syphilis, the VDRL may not go down to 0. It might not become unreactive. Sometimes it might stay 1 in 4, 1 in 2, you know, sometimes 1 in 8. So they will walk around with this VDRL thing for life. And then once you treat them and you see it drops by 4-fold, then you know they're treated. All right, so the TPPA, which is the confirmatory test, is positive for life. So they will always have this positive test, but what we do is you check the history. So you ask them if they've ever been treated, or was the last VDRL? And once you see the VDRL drop more than 4-fold, then you know they were treated. But some people walk around with a positive VDRL and of course a positive TPPA, and this is positive for life. Yeah.
Any other questions from anyone else?
Could be a case.
All right. Well, if not, just transfer to not a very long.
Hello, good afternoon.
Hi.
Yeah, please. My name is Jedida. Please, bearing in mind that syphilis is a multi-organ involvement, is there any collaboration with general medicine in quick diagnosis? Because I saw in most of the outpatient clinic, especially renal clinic, there's nothing towards a communicable disease or infectious disease that may lead to their organ failure. Is there any awareness towards that?
I mean, people should, that's what I'm saying. So syphilis is called a great imitator, all right? So it can affect generally all organs in the body. So any patients who presents with unexplained illness, they need to screen them for syphilis. So I'm not too sure the general medicine physicians do that, but some of them do. So again, as part of a screen, you should do a VDRL, you know? So I agree, it could cause renal problems, it could cause liver problems, it could cause neurological problems, it could cause heart problems. So again, good medicine, you should screen all patients for syphilis. So that's what they need to do. Yeah, I agree with you. They need to screen more.
I know at least from my time in general medicine, they tend to request a VDRL if someone presents with strange neurological.
Yeah, if it's strange symptoms, but syphilis can affect the entire, all the organ system. So it's good to screen, you know?
We had a patient presented with signs of a stroke. And you know, we're treating with aspirin and simvastatin, and we just recommended to do your VDRL. And when it is, it was syphilis. That patient can be completely different cancer.
Yep.
So yeah. All right.